you can start.
All right. Good evening, everyone, and welcome to this next session of our webinar series in the Telehealth subsection, which is a subsection of the Indian Academy of Neurology. And we regularly hold webinars which discuss elements of telemedicine and also artificial intelligence, as we had in the last webinar. So today we have a very accomplished set of speakers with us, and we are going to be discussing very interesting aspects of telemedicine, which is teleeducation and the current status of telestroke networks, although in the West, but it is highly relevant to our country, and we stand to learn a lot today. So without wasting further time, firstly, I'll also welcome my convener, Dr. Biplab Das. He's joined us, and our chairperson has already joined us. So let me first introduce our chairperson for the day, Dr. Professor Partha Ray. He's an honorary IMA National Professor in Neurology and a consultant in neurology and clinical neurophysiology at India. And he's qualified as a DTMH from Kolkata, MD Medicine, and he has an MRCP from UK. A CCST in UK in neurology and clinical neurophysiology, and a life member of a number of associations, including the Telemedicine Society of India, Indian Stroke Association, and Indian Epilepsy Society, and others. Welcome, Professor Partha, and please take over for introducing our speakers today, and let's move forward.
Yeah, thank you, Professor Khurana Dheeraj. That was a very kind introduction. Well, my job today is to facilitate Dr. Deb and Dr. Tegler to educate us and share their experiences in North America so that we can take the global field forward through tele-neurology and tele-education and, of course, tele-strokes. Well, our first speaker for today is Dr. Anindita Deb, who is Associate Professor of Neurology and Neurosurgery. She's a co-chief of movement disorders and director as well of the Global Health, Social Justice, and Advocacy track for neurology residents. And that's, I think, a big role that she's fulfilling there, as well as on her global mode and outlook and vision. She's the director of population and community and global health pathways, and to promote international medical education program. I quite like that because there's never enough doctors in the whole world to look after underserved areas, and that's a great job that she's doing. And health equity is a big area that has always been neglected, but I'm glad to say in the last 5 years, Dr. Deb and others have been pursuing this field. She's at the UMass Chan School of Medicine and UMass Memorial Medical Center. I was looking at the movement disorder portfolio that she has. It's indeed brilliant. But today we'll be focusing on medical education through the tele-neurology network and the global health education. She has got a number of publications. It's all there, very recent ones, the last one from last year only. I'll be particularly interested as a chairperson to see how the traditional mode of teaching at the bedside, which we have all done as clinical students in 3rd year till 5th year, and then as residents, and then went on to pursue bedside ward rounds in the physical space. How does that translate to the virtual space? So, Dr. Deb, without coming between you and the audience who are excited to hear you speak, I hand over the microphone to you. Over to you. Thank you.
Thank you. Thank you so much for that introduction, and thanks for having me. Good afternoon, everyone. Let me share my screen. Okay, so as Dr. Rai mentioned, I'm an associate professor of neurology at UMass Chan, UMass Memorial in Worcester, Massachusetts, about 50 miles west of Boston. And today I'm going to talk about a program that we developed at UMass in teleeducation. Doesn't focus exactly on bedside teaching through telemedicine, although that's another interest of mine. But this is more about teaching global health, and I use that term broadly, to our trainees, and using video conferencing in that mode to kind of get together and learn, not just bi-directionally, but there's 4 sites, so all together. And I'll go a little bit into how this was developed. I have no disclosures relevant to this presentation. So I'll talk about my niche, which is global neurology education, a little bit an overview on education and programming, and then review the development of our curriculum in our global health track for UMass residents. I'll talk about the actual track programming, how we partnered with our partner site, and what the steps towards that, and then our kind of unique, at the time was unique, I would say now is probably not as unique anymore since COVID. I think there are now many video conferenced educational sessions that occur from schools, in the West and schools globally. But I'll talk about how we developed ours and then challenges and opportunities. So I'm sure, this is not a group that's not aware of global health, but this is kind of how I define global health for our trainees when we start this, as the connection between neurology and global neurology was not quite there back when I was starting this in 2016, 2017. It wasn't an intuitive connection. And so usually this is how I'll define it for our trainees: an area of study, research, and practice that places priority on improving health, achieving equity and health for all people, emphasizing transnational issues and interdisciplinary collaboration, and a synthesis of population-based prevention with individual level care. So again, this is, I know, a group that is aware of this, but our disability adjusted life years, our dailies, in terms of neurology and neurological disorders, is growing every year, and it's likely more than this at this point. Keeping in mind that stroke is often part of cardiovascular diseases when looking at the global burden of disease data, which is right at the top there. And so this is the argument I make when I say that neurologists are very much needed and a part of global health. And we also know that global health is integral to medical education in general, because of the interconnectedness of the world, because of a growing interest in global medicine. In the US and Canada, there have been clinical rotations offered since the 1980s. However, in neurology specifically, again, back 5-10 years ago, the number of tracks in global or international health was limited through neurology residency specifically. It's been existing in other fields such as family medicine, OBGYN, emergency medicine, for much longer than in neurology. These are a couple of pictures I included with our partner site and Dr. Soham Desai, who is my collaborator in Gujarat at Sri Krishna Hospital. And the bottom picture is in Haiti, some of my colleagues, who this was now in 2013, 2014 timeframe, when our group from Boston Medical Center, where I trained, we had a group that was going down to Haiti annually to do some teaching on clinical practice of neurology, and these are healthcare workers there. So we also know that global health curricula is of benefit to trainees. We know that they learn from other healthcare systems and systems practices and challenges. They learn about epidemiological change. They learn about determinants of health. And I think in general, they acknowledge a wider kind of medical responsibility for ensuring good health outside of the bubble of where training occurs. Obviously, they'll learn about cooperation, communication among different players and stakeholders that are involved in health, in a global setting, and ultimately develop, hopefully, into a well-rounded professional with an ability to really appreciate cultural diversity through cultural competency. And then this is just to give an idea of the different global health programs at UMass Chan. And these are generally fellowships, global health fellowships in family medicine, psychiatry, pediatrics, emergency medicine, surgery, anesthesia. And then family medicine has a track for residency as well, like neurology. these are some of the organizations, if somebody is starting to think about, oh, I want to start up a global neurology training program, where can I find resources? These are the ones that I can think of that I have looked into. I'm sure there are others at this point, but I know that these organizations have materials available that might support developing a global neurology program. So this is not something completely new at this point, but again, 5 to 10 years ago, it was just starting up. We were just seeing articles popping up in our Green Journal and others about neurology residency training and careers in neurology in a global field, the global burden of neurological disease, and then developing a successful global neurology program. And so when I set out to develop this at UMass, these were the objectives that I wanted for our trainees to really gain an understanding of global health, how it applies to neurological disease, be able to think about risk factors in a broad differential across different populations, which, although global, now we know, global is local. And so we definitely have populations in and around Worcester and Boston who we need to be aware of kind of different risk factors that they've had and different types of diseases that may be common to their population that we need to be aware of. We describe or discuss cultural, political, economic, social influences on health. And then we also apply principles of health equity and social justice when we discuss cases. We try to identify strategies. We often do kind of case-based discussions on, here's a scenario, and how would you think about access to healthcare in this scenario, especially when there's resource-poor areas, underserved populations. And then we incorporate an understanding of health determinants into patient care, which is incredibly important no matter which setting we're practicing in. And of course, cultural sensitivity when communicating with a diverse patient population. And so in this paper that I published in the Green Journal, I outline a framework for developing global health education in a neurology residency. And these are the kind of key points from that paper. I discuss a needs assessment. I'll go through each piece of this kind of step by step, but I discuss a needs assessment, kind of figuring out if there's institutional need on both sides, resources, mentors, and then developing goals and objectives, competencies, which we'll talk about a little bit, partnering with a global site, how to develop the programming in terms of pedagogy, and then technology and program evaluation. For me, these two resources were really important as somebody that was pretty naive to curriculum development. Curran's 6-step approach was very helpful. And Jessica Evert and group's book on developing global health programming with many examples of global health programs around the US was also very helpful as a resource. So in developing a global health curriculum, initially when I started at UMass in 2016, I had to kind of get buy-in from our stakeholders, from our chair, our program director, our residency program director, and the chief residents to see, is this something they were interested in, and kind of make an argument for why this is important. And also obtain protected time for curriculum development and implementation, which I was lucky in that we have a junior faculty development program at UMass that I was a part of when I started, which gave me some of that protected time. And then developed a pilot curriculum, and through that pilot curriculum had to determine kind of timing and frequency. And the main challenge here was that, of course, our neurology residents have a lot of foundational curricula they have to cover in a limited amount of time. And so this was going to be an additional piece, and we had to make the argument for why this was, again, important, and kind of how to do it where it was enough time, but not taking away from their foundational neurology curricula either. And then to keep them engaged, I needed to kind of incorporate didactics, but also keep them engaged through discussions. And so in developing goals and objectives, there really wasn't a whole lot available that was neurology specific, right? There was no global health competencies, at least at that time, through the ACGME. I think there are specific specialties where they have global health fellowships where there may be competencies available, such as through child neurology, but not for adult neurology and global health kind of track or curricula. There have been definitely papers that have been published that discuss various competencies that should be considered, and these were really helpful and kind of provide guidelines. And then I actually went through the Association of Schools and Programs of Public Health Associations, where they have topics related to foundations in public health, interdisciplinary topics, and kind of pulled from there to develop my competencies for our residents. That was just a sample of when I was developing this curriculum, you know, how to put it together, coming up with the various modules, any assessment that I was going to do. Competencies, these are just shorthand for the different competencies. This is the ASPPH1 and the ACGME, and which competencies would be fulfilled and how, and then what kind of content. Was it just didactics, case discussion, seminar style, etc. And then we did pre and post assessments to kind of gauge, you know, were the residents liking this? Do they find this useful? And at the time, this was back when this started in 2016, I had about 20 neurology residents who participated and completed, you know, there was a variation because this was all voluntary, but many of them completed the assessments just to show that there was an interest in global health and that they found that this was relevant to their residency training. They learned a bit about the impact of neurological diseases and the global burden of disease, and being able to identify different neurological diseases specific to different populations. And then also, you know, discussing global collaborations was important. And just like a Likert scale that we used for this. And then the other piece was that I really wanted to collaborate with a global site, and was lucky in that there was some direction from colleagues at UMass already. We actually had a pretty robust and have ongoing robust collaboration with Charita Arogya Mandal and Sri Krishna Hospital in Anand, Gujarat, through various other departments at UMass. So they were already collaborating there for 5 years before I started. And so that was one that seemed like that would be of interest, in that there was already a lot of interest from other groups there. Neurology wasn't quite involved at this point. I wanted to do something in India, given my background, my parents from Kolkata, and so wanted to do something where, you know, was connected to my kind of roots. And then found that this might be an opportunity. So we applied for a travel grant that was through UMass for a site visit and a needs assessment back in 2017, and met with my now collaborator, Dr. Desai, and his team at Sri Krishna Hospital and at the medical college, where we discussed just, you know, what this collaboration could look like, how this could be bi-directional, different projects if trainees were to go there, you know, how would we work together, travel, lodging, and security, some of the logistics, and then also kind of long-term goal alignment. And at that time, they had medicine trainetional but no neurology trainees, and that has changed. But it was nice because we could share educational resources, educational training between our residents and the medical residents there who were rotating through neurology. And so since then, we've sent 2 residents, and I'll go a little bit more into the resident programming, but we've sent at least one medical student a year through neurology. As I mentioned, we have some other collaborations there. So we end up sending at least 3 or 4 other students through some of our other departments as well. And we really are aware of the bidirectional exchange importance in a collaboration. It's been limited, I would say, from the UMass end due to various barriers. Dr. Desai was able to come and visit through a scholars program, I believe it was back in 2018, and visit our hospital and stay with us for a few weeks, and that was very nice. But we are still discussing how we can bring the neurology fellows from Sri Krishna Hospital over to UMass as well for a true bilateral exchange program. And then since 2017, I believe, Dr. Desai's team developed a neurology fellowship program there. And so now they have, I believe, 2 fellows a year. And so this is nice because now we are able to share our cases with the neurology fellows on both sides. So a little bit back to the program development, this track, which we started out as global health, we expanded to cover social justice and advocacy, was more formally established in 2017 since my pilot program. We incorporate at least 4 didactic sessions per year, and that's for the whole residency. And then for the global health track residents, it's voluntary, but those that participate in the track, they have protected time for once a month for an hour. And you can see the range of topics that we cover. Sometimes we leave it up to the trainees on what their interests are and what they would like to cover. Obviously, there's so many topics that we can go into, including we had a recent one as well on AI and kind of global neurology and AI and challenges. And then what I think is unique for our program is that we have a global health morning report once a month. And I'll talk about that in a minute. The requirements to participate in the track are really attendance. They'll often facilitate the discussion sessions with our guidance and a mentored scholarly project, and then they present on that project prior to graduation. So our monthly video conference morning reports are, I think, really the highlight of our track. And this is among 4 sites that are listed here. So I mentioned our collaborating site in Gujarat. We also, I think it's been almost 2 years now that we have had PGI-MER also as one of the sites that participate, American University in Beirut, and then our site at UMass. And these came along due to various connections and collaborations that are ongoing. And so one of our residents had a connection with PGI-MER and, was very kind of enthusiastic about having them or inviting them to participate in our video conference sessions. And so that after some discussions, it seemed like there was interest on both sides and they joined. And one of my colleagues who trained at AUB also wanted to bring them on board. So kind of was our liaison for their participation. And so what we do is we alternate presenting cases from each of these sites once a month. It's part of the resident morning report for us. So it's a required time that our residents, and it tends to work out timing wise. It's definitely evening to, a little late evening, depending on our daylight savings time calendar, but tends to be late evening in India, but it seems to work out where most of the time we have participants from all the sites. And this is faculty facilitated. And so the faculty at each of the sites will facilitate the case that the trainee is presenting. And again, our goal is just like any kind of morning report, case-based discussion, learning about the diagnosis, differential management, but also we try to add in a component of identifying resources, identifying challenges in the various settings, depending on the environmental, political pressures that might be going on, and also challenges to patients themselves and access to care. The cases are selected by the trainees, and then the presentations are reviewed by the faculty from the presenting site, and we have a standardized format that we all try to follow and try to kind of go site by site for questions, just to avoid too much chaos with so many groups online at the same time. And then we incorporate discussion questions throughout for the trainees so they can think through the case and again, highlight some of the diagnostic and management challenges. And we present this monthly, generally from September to June. And so since we've started this, we've had more than 50 unique cases. We're trying to write this up now as well. And so from this track, currently we have a pretty robust participation. Again, it's voluntary, so the residents aren't required to do this, but we have quite a number of our residents that are involved. And we've had 8 residents total who've graduated with, we give them a certificate in global health, social justice, and advocacy during graduation, as we think that this is really important for them to be able to highlight in their CV, discuss, and also incorporate into their careers going forward. And then their mentored projects, as I mentioned, can really vary. We let the trainees come up with their ideas, what their interests are, where their passion is, and also where their connections might be globally. And we try to help them then develop, what their project would look like. So I had a resident who was from Costa Rica who has since gone back to Costa Rica to practice. And she wanted to develop a research curriculum for junior faculty at the University of Costa Rica. And then I had one of our residents who was neuropsychiatry, interested in neuro rehab, and developed a curriculum for our residents in collaboration with the Sarah Rehab Network in Brazil, where our psychiatry department actually has an ongoing collaboration there. Even locally, so we've had some students who wanted to, or residents who wanted to stay locally, and we have our Worcester Islamic Society, which is very active in the community and has a free clinic there, and we were discussing establishing neurological care there. And then also one of our residents developed kind of global neurology curriculum relevant for non-neurologists across UMass. And so, importantly, I think whenever we set out to do something, especially new or related to education, it's important to think about scholarship and how to highlight what's being done. And so we've been lucky enough to have very enthusiastic, engaged trainees. And so you can see some of our poster presentations when we first started this. We presented at various different conferences throughout in the US and then through the CUGH as well. At the time, we had also developed a neurology curriculum, and we were sharing that curriculum between the UMass Neurology site and the and Sri Krishna Hospital site, where our residents came up with kind of foundational neurology curriculum. So just, intro to stroke, intro to migraine, intro to MS. But we found that it didn't quite hit the spot and that it was too basic for some, not enough for others. So that's why we decided to shift from that kind of a format to a case-based discussion, which has been going very well since then. But that curriculum was also shared at AAN and Najia back in 2017. A couple of the students who had traveled there, you can see here, did some projects with Dr. Desai that they were able to present at our movement disorders conferences. And then we've had a few manuscripts as well. The one that I referenced on the framework for developing global health curricula, but also others are my colleagues in medicine and pediatrics who kind of started this collaboration in Gujarat, had a manuscript on trainee-led international initiative. And then this has also, been an opportunity to look at research collaborations, although that's not my primary goal, but I was able to do a project with Dr. Desai on looking at the epidemiology of Parkinson's in that area in rural Gujarat. And then there's a couple of others that are in progress. So of course, with any curriculum and with, any kind of tele-video conferencing, there tends to be challenges. One of them is definitely protected time. Since I started this track, we have established 2 other tracks for residents in education and research, which are, as I mentioned, these are all voluntary, so residents can decide to participate or not. We do ask them to kind of formally commit at some point early in their residency. And then time for the track directors was just kind of formally allocated this year. So before this, we were kind of doing this, voluntary work because we enjoy this. This is our passion. But I do think it's very important because all of this takes a lot of time to develop any curriculum and to administer it. And then the time for the residents to work on their project is obviously limited and requires some gentle nudging at time to time, but they are generally passionate about the topics that we're discussing and that they're pursuing. Funding always comes up, how do you fund the programs? How do you fund the travel? So we don't have specific funding for the educational program itself. The residents are able to, we worked it out with the program director, they get $2,000 to present at an international conference each year. So we do ask them to kind of choose or use part of that if they want to also travel globally. And so they may also be presenting internationally, but they kind of choose how to allocate those funds if they decide to travel. They can also apply for other funding outside of ACGME and UMass, so we help them to identify that. Excuse me. Sustainability, so definitely stakeholder buy-in. This is a unique part of our residency program, so definitely draws a lot of interest and a lot of applicants from around the world because we offer this track. There has to be commitment by the directors of the program because otherwise this could fall apart pretty easily just because of time and funding. And then resident interest, if the residents decide that this is not for them, then this is not going to be sustainable. So kind of keeping up the resident interest, making sure that this is, is relevant to what they're learning and relevant to their education. And then the bidirectional exchanges I mentioned, I really am a big proponent that this is really important in any kind of global partnership. And as I mentioned, it's still a challenge for us because UMass Chan on the med school side has pretty strict rules, not just on international exchange programs, but even not allowing any students to rotate through for shadowing or for observerships at UMass specifically. So that's a longstanding kind of rule at UMass. That's been a barrier for us, but something that we're hopeful that we can work around and hopefully get some of the trainees from Gujarat out here to UMass. Identifying funding mechanisms to support trainees for that visit and sometimes piggybacking on conference opportunities as well. And then for opportunities, as I probably didn't mention, but our residency group is a very diverse group who've trained, generally gone to med school or from other countries around the world, which is great. It's really a wealth of knowledge, but I find that we're not often sharing those personal experiences or training other than in this setting. And you learn a lot about, where others have trained, the different kind of epidemiological patterns they've seen, different diseases they've seen. And I think that's always makes for enriching discussion. I do believe that this contributes to the growth of the person and the physician, this sort of track and case discussions and collaborations. It gives the trainees an opportunity to network with colleagues around the world and exposure to various healthcare systems and the challenges that arise in those systems. Hopefully, we're training more culturally competent physicians, and this also opens the door for research collaborations. And this is my my references. So thank you so much for the invite and for your attention.
Thank you, Dr. Deb. That was absolutely fascinating, wonderful. And that too from a person who has got antecedents from Kolkata. I'm very grateful. I'm from there as well. Right. And thank you for
just
sticking
for a
to
short
time.
break before we go into another great lecture. This was amazing, Anandita, and very enlightening and in fact, very stimulating lecture.
Very.
And PGI is already part of the program, but I wasn't aware that you're involved in that program because residents do tell me that they have this discussion once a month or so. So before we go on to the next lecture, I take this opportunity to welcome our president of the Indian Academy of Neurology, Dr. Debashish, and the past president, Dr. Nirmal Surya. They are here with us. It's really great of them to join. And sir, would you like to please say a few words?
So thank you for the invitation. And I heard the lecture. I mean, it's very nice. And so much work has been done. And I think Indian Academy of Neurology will take this further on. And recently I had gone for this American Academy of Neurology annual meeting. And there I had a discussion with Professor Carolyn Jackson and Natalia Rost, the president and president-elect. And we have charted out a lot of programs for bilateral relationships to enhance our, neurological care, neurological treatment, neurological education. And I think this is a right step towards it. And thank you, Dr. Anandita, for a very, very good lecture. Thank you.
So, Dr. Partha, so maybe you can.
Yeah.
Continue, and
Yeah.
please introduce.
I'll cut. Right. Is that everything? Okay. Right. So it's my privilege now to introduce Professor Charles Tegeler. Uh, uh, well, what can I say? A very illustrative career. Well, presently his designation and affiliation are that he is the McKinney Avant Professor and Chair, Department of Neurology, Wake Forest University School of Medicine, and is the convening academic neurology chair of Advocate Health as well. His areas of interest are in neurovascular ultrasound, stroke prevention and treatment, and of course, telestroke. That's what will be the focus of today's talk, which I very much look forward to hearing. He's also got topics on acoustic neuromodulation for stress, anxiety, and insomnia. He's got the Lifetime Achievement Award from the American Society of Neuroimaging, and he is also the committee member of an advisor to the board of directors of the American Society of Neuroimaging. So I was looking at his publications yesterday, and it's actually a huge and immense, fascinating. So without standing between you and Professor Tegeler, I'd hand over the microphone to him and let him carry on. Thank you. Professor Tegeler, the floor is yours.
Great. Let me share my screen here. There we go. And so can you all see the slides?
Sir. So click on the share screen icon, which is on your screen, bit of your screen.
Thought we already were sharing, but let me try again. There we
Select
go.
your PowerPoint.
All right, let's try this time then. There, is that better?
Yes, perfect.
Excellent. Well, thank you all so much. And I agree with you. That was a fascinating lecture. I learned some things. I took some notes, and I'm going to go back to our residency program directors and ask why we're not doing that here at Wake Forest with some of those things. But thank you for the chance to share a little bit of my journey in this area of telestroke. Before even starting, I have to tell you that over, gosh, now 39 years of academic neurology practice, very few things I have done have been any more gratifying than the work that I've done with helping to set up and develop this telestroke program and network. I really feel like we've made a difference and changed care, changed medical practice in North Carolina. And I hope you can see that as we kind of go through things. I'll try not to bore you with too much, and hopefully just stimulate you, give you some ideas about what might be done, what you might do, how you might do it better, and push the field forward across India with your organization. So again, thank you for the kind introduction, and we'll get started. I'm going to start with a case that really kind of highlighted to me early on in our practice with this, the importance of having this involvement. So the 77-year-old right-handed man with hypertension and hyperlipidemia was drinking coffee on the deck at his vacation home in the mountains in North Carolina. And at 8:30 in the morning, he was observed by family to slump over, hold his head, became unresponsive. There may have been some asymmetry of his face. They weren't really sure. But the emergency medical staff, the ambulance drivers, EMS folks, found him unresponsive with pinpoint pupils. Now, he had a history of a traumatic brain injury because he fell on the ice about 6 years before that. There was no clear jerking or seizure activity, but his wife noted movement of his legs of some sort. The initial NIH stroke scale that the emergency department reported was 36. Any of you who take care of stroke patients know that that's horrible. I mean, that's almost dead, and so that's what we were faced with. So this was a small hospital that we work with our telestroke network, and they activated our telestroke network at 10 o'clock in the morning. And I called the emergency room doctor at 10:05, and I was told the patient was now awake, moving all extremities and responding verbally with an NIH stroke scale score of 0. Vital signs were unremarkable. So I said, well, I need to see what's going on. So I did the virtual consult, beamed in, if you will, at 10 minutes after 10. And when I got there virtually, the patient was unresponsive. His NIH stroke scale, I repeated it, and it was conservatively 30. Again, virtually no response. And I had them do some other maneuvers, and I observed bilateral upgoing Babinski's with triple flexion withdrawal. Looked at the CT scan at 10:25, and I'll show you that in a moment. There was no hemorrhage, but this was the CAT scan. And so again, not just seeing the patient, but looking at the imaging nowadays can give you lots of clues and be helpful. So this was the CAT scan, and without belaboring it, you could see there was asymmetry here, wasn't there? I mean, there was some atrophy on that left side of his brain, but did that have anything to do with what was going on? Well, hard to say, but there was some atrophy and enlarged CSF space, but the midline also appeared a little asymmetric, but it appeared chronic. It didn't look like it was a new thing. So we talked about all the options with the patient and the family. And at that point, I recommended TPA, because I didn't see anything that really was a contraindication, and this guy was virtually dead. So we gave TPA the usual approach there. The emergency medical folks, the ambulance transported him to our hospital. En route, he actually started posturing. Didn't sound good. But 10 minutes later, the ambulance drivers and the EMS techs reported that he started getting better. When he got to our emergency room and to the neuro ICU, he was normal, except for those bilateral upgoing toes. He spent the night in the ICU and was discharged on day 2 with no deficits. So you say, well, why am I showing this? So, well, here was some interesting insights afterwards. So here was his CTA. This is an AP view showing the basilar artery perfectly open. But look what the MRI showed, the DWI showed. There were tiny little areas here of restricted diffusion in kind of the bilateral medial thalamic regions, suggesting he'd had top of the basilar, pathophysiology or syndrome. So this just, it was just a great example of how important it is to be able to interact with the patient in this quickly, dynamically changing setting of acute stroke, and to view the imaging, to talk to the patient, to talk to the family, talk to the doctors, and to really come up with the best answers. And so we thought this individual probably was closing off his basilar artery, leading to that huge, horrible symptoms. But lucky for him, maybe the TPA helped, maybe not, but it opened up, and he ended up with very little residual and went home, just within a day or two. So as a jumping off point, then I want to just kind of briefly today walk through a little of the background and development of telestroke. Focus on some of the development and what we've done here, the overview of our own telemedicine or telestroke system, I should say. A little bit about where we are with telestroke overall, but then some thoughts on the future, and hopefully stimulating, encouraging, inspiring you to do even better, and to go different directions. So, why telestroke? And again, I'll try not to bore you with the details, because most of this is focused on what's happening in the United States. But these are some maps that go back a few years, but show that we have, areas in the United States where the stroke death rate is very high compared to the rest of the nation. You can see that the stroke belt, if you will, is largely here in the Southeast United States. And yet, as you look at where the doctors are, based on some older data, but still valid, where are the doctors that can help do that? And the neurologists, the stroke docs especially, my goodness, that's right in the area where there really is much greater demand than docs. So there's a mismatch between what's available and what's needed. Even in North Carolina, if you look at this map, so on this particular map on the top, the darker shades are where there's higher death rates in those counties. So we have roughly 100 counties in North Carolina, and where I am up here in the northwest part of the state, right here where this the arrow is in this kind of pink area, there we have excess stroke death rate, but it's really bad here as we move towards the coast over in the Sandhills and eastern part of North Carolina. And yet, if you look at the map of where a few years ago, where the primary stroke centers and the comprehensive stroke centers are in the state, they're not there. There's a mismatch between where the high stroke death rates are over here in the eastern part of the state and where the services are. So I mean, that's wow, that's a problem. And so, that's one of the reasons, one of the justifications for telestroke and why it was so important to develop. Again, why? Of course, you all know this, but I have to reiterate: time is brain. We try to avoid all delays. We have multiple options now with systemic thrombolysis. We started out with Alteplase, and we have now transitioned our network all to Tenecteplase, just because it's a quick administration and cheaper and a lot of other things. And of course, now we have thrombectomy. And so we're having to look at patients that come in these small hospitals up to 24 hours to consider for that. And more recently, I know you're aware that thrombectomy has been expanded to even consideration for large core infarcts, with some of the outcomes more recently. So we have a reason to be trying to identify these people and get them to the place that they need to be to get the kind of care they need to improve outcomes quickly. So the reality, as we showed, is there's inadequate stroke expertise available, especially in those small hospitals and rural areas. Again, the quick shot. This is where the hospital, there's about, I think, I don't know, 150 hospitals in North Carolina. You can see them all arrayed here. But look at the only ones that at the time this was done, this was when we started our network. Look at the few number that really were stroke capable, that gave TPA even, and so there really was a mismatch. Now, telestroke has evolved rapidly. We were in the game back here when it was starting. Some of the history of it. We started developing our network in 2008. Our first hospital, as you'll see, launched in 2009. But there were lots of publications. Folks did amazing work, and to show that this was feasible and that it could be beneficial to lots of patients. Lots of great work was done. But it all was kind of focusing on leveraging this, which is, the hierarchy. So we love to see everybody face to face. We can't. There's not enough doctors. They're not distributed properly. So, the development of technology allowed this, the two-way audio video telemedicine synchronous approach. Then, of course, there's telephone consultation and all kinds of other lesser involved, lesser engaged modalities. And of course, then asynchronous consults, the e-consult that y'all, I'm sure, do every day as well. And there's lots of ways you could deploy it. So traditionally, it was the hub and spoke. So the academic medical center with all these other little hospitals that we were serving, and some were sending us patients, some were not, those kinds of things. But it can get really complex, and our own system helped kind of showed that. So we had our main thing. We had some hospitals that we worked with that were unaffiliated with anybody else and were outside of our purview. But we had other hubs, sub-hubs, or kind of secondary hubs that that got patients from other sites that we worked with, or that get patients from other sites. So it gets really complicated, or can get complicated. Again, why did we do it? Well, the limited time window, we have to try to get people access to care quickly. There were those gaps in access. And we needed to get them stroke treatment without waiting for them to be transported to the Mecca, to the ivory tower. So we really we had a big vision. We wanted to improve stroke care across the state. We wanted to increase the use of those proven therapies. We wanted to keep patients local if we could, encourage local care, but facilitate transfer for those that needed higher levels of care, and avoid unnecessary transfers. You don't want to transfer someone 80, 100, 120 miles when they could stay local. I mean, that's just it's not optimal. We also wanted to try to use this as a management tool to kind of enhance the relationships between us and our hospitals that we work with, and to just improve care in general. So again, our model, so we have many places that we are a regional hub and spoke traditional model, where we can transfer patients in and offer them preferred bed placement, guaranteed placement. but we also work with other sites across the state, other academic medical center that didn't have the resources and people. And so we provide telestroke for them, and they bring their patients to their hospital, 300 miles from here. And so really was quite an interesting model. And again, it gets more complicated when you start adding in all those variations. So as we got into it, I have to watch my time because I could blither on a long time. But if you're getting into this in your hospital or for your health system or for the nation, even because there are opportunities there for a big impact. You have to look at what technology and equipment's available. Are there vendors you can use? We started out with InTouch. Now it's Teledoc that we work with. You have to have people to do it. And who are you going to have do it? Neurohospitalists or stroke docs, vascular neurologists. It's a whole different ball game. You have to see what your resources are. In the United States, we get in trouble with licensure and credentialing across state lines. So right now it's our state, but if you get licensed, if you're going to work with Virginia or South Carolina, you have to be licensed there as well. So it gets complicated. And how are you going to cover call? So we started out with 4 vascular neurologists. Probably 5 is ideal. Less than that, you're going to burn them out quick, and it's going to all fail. So just be aware of that. The business model, how you going to get paid, fee for service for per click, or a retainer fee for access. There are lots of different ways to do that. You could try to bill and get reimbursed for them. We did not find that to be very helpful and successful. It took too much investment to do the billing. And then, of course, a very important quality assurance and quality improvement. So what did we end up with? And this old picture, I didn't have quite as much gray hair back then. But we ended up with 24/7 easy access to our stroke docs. That was our asset, was our vascular neurologist. But it is a multidisciplinary team, interventional, neurosurgery, all kinds of people that we have to engage. But we called just a 1-800 number, a toll-free number, and we offered them guaranteed bed placement if they needed to come to our hospital. But we also engaged with a variety of other things. And as I heard the first lecture this morning, I should have added education on this, but all kinds of help with their own program and protocol development, outcome monitoring, QI, in-service. We did have education, in-service and CME. And so we really use it for a lot of other things as well. This is what we've used for years. Video consults where we had the NIH stroke scale stuff that we could show the patient, and the video connection really zooming in close on things. I mean, you can watch people's pupils, constrict and dilate with the current video technology. Is really amazing. And so what did we end up with? So we signed our initial hospital back in November of 2009. Went live with our first hospital in December that year. So we've been at it 15 years almost, not quite. We expanded to 21 hospitals across North Carolina that we served for many years. 11 of those were regional. So 11 of those we would get patients to our hospital from potentially. 10 of them across the state. We had no expectation of any transfers. It was really just providing that service, especially in the part of the state where there was no stroke neurologist, there was no neurologist, to help. And again, I'm so gratified by the results because we believe we really helped to change the expectations for acute stroke care across the state. Now across North Carolina, people expect to have access to stroke expertise when they go to the emergency room. Back then, it wasn't the expectation. So it really has helped change the outlook. And what have we done? So as of February, I think it was, getting close to 18,000 activations. So I've probably done 3,000 or 4,000 of those myself. We beamed into 60, 65, 6,600 of them across the board. If we beamed in to see them, 41% of those got thrombolytics. They got IV thrombolytics. So, again, many of those places, the emergency room docs were not willing to give TPA or now TNK without help. So I think we really changed the conversation. Here's another kind of a visual of our network. We have our regional hospitals here, but we also developed a whole bunch of them in the eastern part of the state where they really didn't have the resources before. Thought we made a big difference there. Now, what was the activations? What was the activity? So early on, we thought it was really busy. Well, we had no idea, but as we added more and you know, as COVID hit later on too, you know, the number of activations skyrocketed. So we're routinely, you know, getting up 200, getting close to 220, 230 activations a month. And these are the beam-ins that we actually saw, you know, when we went in to see them virtually as well. So it's continued. It's they're not just wasting the time having the you know, the computer and the robot there. Now this was a graphic from back in 2016. When we started in 2009, there was no telestroke in North Carolina. So it rapidly evolved, and here was our network in purple here. But there were really about 5 different networks, 5 or 6 across the state. You can see them here. And now currently with mergers and acquisitions, the purple one here and this light blue one, we're one and the same now. So we have merged. Now there's a separate network, but we're part of Atrium Health now. And so, you know, we're going to probably try to leverage to increase the size of it across the state. I will mention that, you know, we hoped we could change access, change the map, if you will. And so here was what it was looking like kind of before telestroke, and then after we worked with the hospital in the eastern part of the state, we really were able to get a lot more Joint Commission stroke ready, or even primary stroke centers stand up those across the eastern part of the state. So I think we feel like we made a big difference and a different way of looking at it. Again, the high risk area in the eastern part of the state. And here was what the map looked like initially, and then we were able to add a whole lot of other sites, you know, with our remote help telestroke with that. So again, across North Carolina, we now have 10 comprehensive stroke centers, 12 comprehensive stroke centers and or thrombolysis capable. Thrombectomy capable, 35 primary stroke centers, 9 acute stroke ready. So now where there were none to start with, we now have over 70 hospitals that use telestroke in North Carolina. So it can really be a rapid development and make a huge difference. So let me transition in the last few minutes to the kind of future potential and continued barriers for telemedicine, for telestroke. So we've been rocking along and made a big difference. But as you know, in 2020 with COVID, telehealth really reached a tipping point. You know, we've been kind of pushing the boulder up the hill and kind of having some success, but then setbacks, the Sisyphus effect, you know, for a long time. But COVID changed that. That got us over the hump because, you know, we couldn't see patients and we had to have remote ways of doing it. So now it's kind of, we think, the snowball effect. And where can we take that? What can we accomplish with the technology and with the acceptance of telemedicine? So here's what we've been doing for years, and you know, lots of places all over the world have with the telestroke sort of acute assessment. But then, you know, the telemedicine follow-ups, the telestroke consults, the follow-ups in the hospital, or just teleneurology consults in the hospital for system hospitals, remote hospitals that don't have neurologists, let alone the follow-ups afterwards, you know, monitoring for blood pressure using telemedicine in the room or in the home or even in the hospital to reach out, follow-up visits. Maybe they don't need to drive 2 hours to do that, or you know, or other kinds of things. I'll only mention though that it's not all roses, a bed of roses. Access is not universal for a variety of reasons. You know, language, ethnicity, gender, age, whether you're in a metropolitan area, what your insurance coverage. You know, that makes the difference in whether you have access, or other things as well. In our own system, we found age, race, gender, and insurance made a big difference in whether you had access to it. So we've got a lot of work to do in the disparities. COVID made a big change. You know, we really used a lot of telemedicine. But when people could come back in the clinic, they still prefer the in-person. So not sure where this will head, you know, but we think there's still huge opportunity. And it's not just a matter of those things we mentioned, broadband access. I don't know in India whether you have broadband access, like, that's excellent across the country. We've got that, but we still have areas of low physician access that we have room to work in. So what about other telehealth beyond it too? So, follow-up visits, could we see new patients? Wow, some things where you might be able to do it without a big physical exam component that might work. Others, it wouldn't be so much. Do you need ancillary services? Could you use it to educate patients and caregivers and medical learners, as we heard in the first lecture, and even the public? But how can we expand access to care? And the optimal process is probably a combination of in-person and telehealth, including the phone. And there's lots of other care models that we talked about briefly: e-consults, teleconsults, chronic care management. We're doing some of that. Multidisciplinary clinics, stroke education, support groups. The sky is really the limit. So what will it take to get there? Well, you need a system in place that meets patients where they are. You have to really gear it to that individual patient, but you can expand the options of what it looks like and address health disparities in access to care. And of course, what do you need? Infrastructure, tech support, health system buy-in and adaptation, and of course, reimbursement is always a big deal. And so we'll kind of close with just 2 slides. The future of telehealth. So we can expand access to care. We can help address those disparities. You'll need to try to figure out about reimbursement. We have to in the United States. How can we make sure it gets paid for? But explore all the possibilities. Leverage the power of big data. You talked about AI in the introduction with other sessions you've had. If you set up a network, a telestroke network that covers big systems, multiple systems, think of the power of what you could do with that data to improve care. Monitor outcomes, have to acknowledge limitations like the broadband, like the age, all kinds of other things, and address those disparities. But I love this one. When nothing is certain, anything is possible. So anything's possible with this. And I'll close with these few thoughts. Telestroke has already changed medical practice. Again, one of the most gratifying things I've been part of in my career. But it's a team sport, multidisciplinary team sport. The technology makes it possible, but it's the people that make it happen. And it's all about relationships in all aspects of the system you might put together. Build your program to provide the best care for each individual patient, but leverage the health system vision for function and for impact. And I'll close with saying, be bold, be creative, be innovative, think outside the box, to address patient and health system needs, improve outcomes, and change healthcare in India. And with that, I will stop my slides and say thank you so much for your attention. I'll stop sharing and pass the baton back. And I know that was sort of maybe low on the meat, lots of bones and not much meat, but I hope that was helpful as you're considering what to do to really change practice and change care in India.
Professor Tegler, that was absolutely visionary, profound, and there was lots of meat on the bone. In fact, there was hardly any bones, and I enjoyed every bit of it. You're a true visionary, and you have put your vision into practice in your area of the world. And thank you for, wishing that we in India could learn from your successes as well as from any feedback of how to improve your practice. And that would be wonderful. So basically, it was really a visionary talk. And I was basically looking at the regional disparities, including in your own backyard in North Carolina, and
Yes.
the disparities and the geographical disparities of the doctors and the disease, sync, as it were, and any elaboration on big data and population disease prevalences to set up stroke centers where the patients are. And I really liked the idea that the systems need to be in place to gear the needs of the individual patient. And that's what matters in the greater scheme of things. And we, of course, learned about your reimbursement and how to get the payment for the services offered. So all that was very comprehensive. Right. So we see Professor Nirmal Surya here and Dr. Khurana, Professor Khurana.
Thanks, Partha. And it was truly stimulating and thought-provoking both, because so many ideas emanated from both the talks, and Dr. Tegler especially. We've been learning gradually, slowly about telestroke networks for our country, but implementation has always been a challenge. We've been challenged by implementing into huge areas, and like you mentioned, maybe one of those things is about reimbursements in our country, and we need to think about those issues apart from, of course, integrating the technology with the human resources. So those are major challenges that we face, and we truly have a huge burden, and a big benefit is going to be accrued if we really put into place telestroke networks, effective, workable solutions for our countries. Things are already in place. I mean to say, they are already evolving, and we are looking forward for more data to come in from how telestroke networks are performing in our country. So we hope to see a lot of good things happening in the future. Dr. Nirmal, he's here with us, and we would really like to hear his thoughts.
Yeah. No, thank you, Dheeraj, and thank you, Partha, Biplab. It was a wonderful talk both of you have given, and I think COVID has definitely changed the prospects of looking at telemedicine in such. In fact, I think we need to go beyond only the telestroke acute care. What we need to expand the telestroke network is that we should include a primary prevention. We should continue to address the acute care, and we should add the tele-rehabilitation. I've been trying to convince the stroke specialists that tele-rehabilitation has to be part of the telestroke. Though we have a lot of challenges like how do we measure the thing, how do we standardize the treatment. But I think, as you rightly said, the follow-ups become much more easy for telestroke, which saves a lot of money, a lot of time, and also the travel for the people who are living in rural area. If we work out and come out with a real standardized protocol for everyone. See, thing is, your network is very good. You are doing it in US. Dheeraj has developed a network in India, which also did well. If we can all add together to build up rather than everybody building up their own, and build up a robust system which can take care of primary prevention, treatment during the hospital in ICU and post ICU, and then the rehabilitation. I think that will be the most appropriate and the best possible service we could be offering to the world.
Totally agree.
Exactly.
Thank you.
So if there are any questions we could take from the audience, let me just look into the questions which have come up. Meets patient, they are very interesting. And so there is just a comment by Mohammed Rahman. It says, meets patients where there are very interesting and practical. So basically he's commenting for the benefits of the telestroke. Apart from that, I think Soham was also in the audience. If he's there, I could invite him for his experience with the tele-education that we had. I don't know if he's still there, but I had seen his name in the audience since he had the initial chance of setting up the tele-education.
Yeah. Does Professor Debashish want to say something on Professor Tegler's talk, please?
Yes, sure.
I think the talk was very, very good and timely. And that has given, as Dheeraj just said, a lot of inputs for us to work on our models and improve them. I think, developing a program is good, but it has to be accepted. For those who is internet, they should be able to accept it. Now in India, I'll tell you the problem, because we are also doing the stroke management. The problem comes when the things do not go well. when the patients develop complications,
Mm.
So I think that thing also needs to be taken into account when we develop the model, as well as create the services and the pathways. And also, I think that if what happens that if only, as Nirmal has said, that if only we focus on the acute part, and then the patients are abandoned, they feel lost, they feel cheated, right? So I think there has to be a comprehensive continuum of services that needs to be built up, so that it is integrated within that system, and the patients feel that, well, starting from my disease onset, right from that time up to the rehabilitation, and when I am made functionally independent, up to that point, I am the doctors and the healthcare providers are giving me good support. I think we should think from that point of view, and I ask Dheeraj to kind of look into it. And as you know, that this time from Indian Academy of Neurology, we have started a program called Mission Stroke. So we will be dividing the country into 4 zones, and in each zone we are providing starting to provide this basic structure for the tele-stroke program, for the awareness program, for the physicians to know when to refer the patients, because in India, although we have the structured the primary, secondary and tertiary care level of services, but it is not uniformly followed. People can come directly to a tertiary care center without going into primary center, and vice versa. So therefore, we need to develop a system where everybody knows, the patient knows, the caregiver knows, the doctors know, and the neurologists know what to do and how they can all be integrated. So we have started this program, and I think it will be rolled out in another 3 months time. Professor Salja is in charge of that, and I hope that this telestroke program shall also be integrated with it. And secondly, I think that in the US, I heard that Dr. Dilip, who has been front runner for the program called Mission Thrombectomy. So that part should also be incorporated now, because now we have a lot of available centers, of course, in the Western world, but also developing centers in India, which can, after the thrombolysis, they can go in and do the thrombectomy if needed, if there is a large vessel occlusion. So that should also be thought about and be part of this thing. So this is my overall thinking on this, and I hope that we can together make a difference for our patients' lives. Thank you.
We have Biplab.
Thank you,
Biplab.
Dr. Abhishek. That I think
Biplab
would be
yeah.
an excellent initiative, as we do need IN to really give us a backing in terms of setting up the framework for I think this framework is very needed in our country for the telestroke systems. And I think also we need some to create some awareness and advocacy in terms of the issues that you were mentioning, whether people are afraid that complications might happen. So those guidelines, or maybe certain issues concerned with the advocacy, if they could be written, we need to write to the right people in the government,
Right.
and we could get those things clarified or issued out into the guidelines. Since we've just had a single guideline which came out in an emergency during COVID, there have been no modifications by.
So as a start, I can tell you that now we, as a country, we have drafted the NABH guidelines for starting a stroke center. For the accreditation of the stroke centers. So I was a part of that committee, me, Dr. Padma, and probably you were also there, probably. So we as a start, we are starting all these kind of guidelines, but I think we have a long way to go.
Yeah. Biplab, carry on. Yeah, as a neurointerventionalist. Yeah.
Yes.
So hi everyone. So this is a wonderful talk. So one questions I have to Dr. Charles. So you've been doing lots of telestroke thrombolysis programs. So as already mentioned, Dr. Khurana and others. So one of the major challenge in Indian setup is you don't have any uniform system of transferring patients to endoscopic hub model, number one. And the number two is the complication. Right? So in your setup, you have a hub and spoke model. So in your peripheral center, the primary center from where you are advising to give the thrombolysis. So who is thrombolizing actually? So the minimum training for the doctors, what is the doctor? Is there any certifications program you are doing to give the certificate to start the thrombolysis? So in major hiccup in Indian setup is nobody wants to start thrombolysis at their centers because they are so scared that if there is a bleeding, who is going to be the responsible person, right? So we don't have any uniform system in that way. So I think there is some certification program which can start, and that might help you down that. But how you are doing at your centers?
Yeah, that's a great question. And that's what we really were facing when we first started, because our emergency room physicians who were seeing the patients did not want to give TPA, back then. The emergency room societies didn't even believe, the TPA study results, back then. And so it's there's still some reluctance. So what you allude to, though, most of the places that we work with do not have a neurologist. Most of them don't. So it's the emergency room doctors that are actually writing the orders. But on our end, what we did was our biggest resource was our vascular neurologist. So we had, stroke trained folks that were doing the consults, and making the advisings. And so we've kind of stuck with that. Now, a lot of places, and we may have to as well, start using, neurologists, neurohospitalists who take care of strokes too, but maybe aren't vascular, certified to do that. But that's how we did it. Was we offered expertise, special expertise in stroke, and being there to help them at their bedside virtually. And so the emergency room doctors really liked that. But it was also with the assurance that if there was any complication, any hemorrhage, that they could send them, or more importantly, for many of those patients or many of those hospitals where they don't have a neurologist, up front they said, if we give TPA, then we need to know that we can transfer that patient to your hospital for post TPA care. So pretty much those little hospitals, they were willing to work with us and to offer TPA, now TNK, but they wanted those patients transferred to our hospital, so they didn't have their regular hospitalist looking after those patients, post thrombolysis. Now, some of our hospitals do have a neurologist, even though we still do the telestroke consults. But if they get it, those places, they can get admitted to that hospital, stay locally, and have the local neurologist do the follow-up. But you're right, there's great reluctance because it's not treatments that are without risk. What you do with intervention, nowadays we have to actually have the system set up so we can identify those people that need to come to us quickly to have access to thrombectomy. So most of our hospitals have rapid software. There's lots of softwares out there, but so we can do CTA, CTP if need be, and see whether it's appropriate to send them in even after they get IV thrombolysis. So great question, and yeah, there's a lot of challenges along the way.
Yeah.
Well, let's give Professor Tegler a break because after his talk and multiple questions towards him, let's shift gears and ask Dr. Deb a few questions. Well, Dr. Deb, I found your talk very good because you are giving back to India and your antecedents you shared. Global health is really a good concept, and you are actually walking the talk as well, and I liked it. Your concepts about health equity, advocacy, problems of big countries, and we saw what's happening in North Carolina, the great disparities. So nobody is immune to great health disparities among the population base. And we're not even talking about Canada in North America or countries in Africa or even big countries like Russia. And of course, India is ours. So we need to solve the problems, learning from your experiences. Well, my question was education, because that's where it all starts. Now, you have done pioneering work and you have shared with us your experiences of holding your hands out and shaking hands with Soham, our good friend in Gujarat. And maybe you would hold our hands in the eastern side as well. Now, the question was, do you see the virtual format of education that you are propounding, the tele-education? I'm starting from the basic third year to the residency levels on to the virtual ward rounds. is that a possibility in the near future? Because models of teaching will have to change from 200 years ago, from, Gower's rounds going on to the virtual Professor Deb's rounds in virtually conducted in the near future. That's where I think we want to be in 10 years' time, where students will get accreditations, credentialing, and patients will also feel satisfied. And we have a few questions which we will take up about patients preferring face-to-face and avoiding the virtual, because there's something, there's haptics as well from the examination point of view, which Professor Nirmal Surya and me are quite interested about, how to fulfill that gap. But patients also like the physical presence within a handshaking distance of the doctor. How can we make that feasible on the virtual format? Otherwise, there's no chance you will be reaching out to your remote patients in North Carolina or in Saskatchewan or even in northeastern India. So we need to be having health equity and reach the last person, last mile person. So public education, teaching doctors, and there are colleagues of ours, in far-flung districts of India who are actually 200 kilometers away from the nearest, tertiary center. Let's forget the stroke centers. Even to start TPA, I know it won't work for large vessel occlusions, but at least getting the process started when time is brain. How do you see that coming from your pioneering perspectives?
Yeah, it's a very good question. Lots of challenges there. I think that, through COVID, we kind of had a little glimpse into what the world can look like if everything was through telehealth, right? So in movement disorders, telemovement has been ongoing. The Canadian system has had it, for well before COVID, and doing it quite well in terms of movement disorders across Canada. I would say that for an exam, like a movement disorders exam, there's definitely some challenges, right? You need to feel tone. You can't assess tone through a video, but you can assess gait. You can see some parts of it. You won't get a full neurological exam. So I think there's the challenges with, like, how do we adapt our exam, or are there features of the exam we need to focus on when we're teaching? I think teaching how to do a neuro exam through televideo is very different than teaching a neuro exam in person, right? And the trainees, there are televideo or telehealth curricula now to teach the trainees. And I think they do need to teach, or we need to teach them how to do it appropriately through video, because, I think at least in the States, everyone will be exposed to that at some level. From the patient perspective, definitely, especially with my Parkinson's patients, they want to come into the clinic. Most of them are retired. They're like, I want to come in and talk to you and see you. What I found is that, so where we are, we serve Central and Western Mass, which is quite underserved compared to Eastern, like around Boston area. And so we end up bringing patients in when we can for their first time visit. And then I end up doing a lot of telehealth or alternating for follow-up visits. And to be honest, some patients want to be just purely tele, because it is a 2 to 3 hour drive for them to get in to the hospital. It's not ideal for me, but I think that once I've seen them and evaluated them once, at least I have some idea. Until their exam changes or other complications come up, we can do quite a bit through telehealth. As we know, a lot of neurology is in the history, right? So I think there's a lot that we can tell through just video, but I don't think it can replace a in-person exam fully. That being said, looking at access and disparities, it's better to have some contact and communication than nothing at all. And we were looking at, this has been done in many parts of the world, looking at using video, even iPhone or some sort of video to get an exam. I think another network to think about to help with that are community healthcare workers. I think that's across the board in neurology and outside of neurology. Training community healthcare workers so that they can either do parts of an exam or video, and then getting that to a neurologist could be really helpful in gaining access. So they're already doing this. There have been studies across India where this has been done in remote areas, definitely for, Parkinson's. But I could see something like that where you could train community healthcare workers. Well, even looking at that in Worcester, right? How do we train community healthcare workers because then they get that in-person contact with somebody, but it doesn't have to be at the level of expertise that a neurologist or a subspecialist would have, but still be able to get some access to care. So I think there's different models to think about, but there'll definitely be challenges as we go forward.
There's huge potential, and I think we tend to benefit a lot once, as more and more of such kind of programs get implemented, especially in not only in India and other underserved areas where education is not reaching out to many people. So let's take a couple of questions which have come up
in the box, yeah,
from our So one of the questions, an anonymous attendee, is in patients. In India, patients don't like virtual consultations and they want face-to-face. So how do we address this situation? The specific attendee has had the same experience during COVID. So if Dr. Tegler or Dr. Nanta, could you address this? How would you think we could address this situation? Because we face this often. We talk to the patients on a teleconsult and they would still like to come down to the hospital.
Well, I'll take a stab at it, and then please fill in and correct me. So that's a challenge, and yet that's what we saw in the curves. More people really like seeing the doctor face to face. The reality is, we heard about it in the first talk. There's disparities. There's not availability. So the challenge will be that if the patient really doesn't want to be seen by a video, consult or follow-up of some sort, then it's going to take time. I mean that, they're going to have to wait 6 months. So for our movement disorders doc, if they want to be seen for DBS in our institution, if they miss an appointment, it's going to be close to a year until they can get another appointment. I mean, that's horrible. And so I don't know where the trade-off is, but maybe some of the educating some of the folks that yeah, you can do this and it works, I think probably as we move forward in the next decade, the younger generation that's more used to interacting on video, on electronic media, shall we say, and kind of some less of us with lots of gray hair, that really preferred the inpatient or the in-person consults.
Yeah.
That we may see a shift with that too, but there is not a great answer for that. We have to try, we do what the patient wants, but the trade-off is that it may take them months, to get seen, and there's just not any good way around that.
I agree. That's one of the ways of convincing them.
I'll wait for Dr. Deb to answer that question,
Yeah,
and I'll chip in with my 2 cents there. Dr. Deb, what's your answer to the question?
I agree with that. I think it's, this comes up often, and it's exactly that. I'll say, I could see you by telehealth tomorrow. I could see you in person in 6 months. And often, they want to at least have that discussion sooner. But I do think, like, in populations where there's lower medical literacy, it does have to do with educating and kind of raising awareness. Like, this is why it's important, not just because you can't be seen sooner, but all the consequences of that, I think, are what patients often don't know. Right? We see this in Parkinson's. When I went to India, and it's like, people are just like, oh, they're just old, right? They just have a little bit of shuffling and tremor, but this will get worse unless you get seen. And this is why, and this is how we can help. I think that kind of just basic education is important. And again, involving kind of other healthcare workers in that process can be really important.
Well, I think the problem actually lies with doctors. We like to see patients, certainly the older ones like me, prefer to see patients in the flesh because of the haptics, because of the way we have been tutored. I'm sure the millennials will look at it differently, and they'll be interacting better on the virtual format. And I'm beginning to become as good on the virtual format. And I see that as much more enabling. I can see patients at any hours. There's less carbon footprint on both sides. And I think it's just as good. Certainly for the history taking. In neurology, I speak for only, not for interventional surgeons and things. Then one has to come in. But that cuts out 80 to 90% of the workload straight away, makes it so much fulfilling, time efficient, carbon footprint inefficient. I think the only problem might be reimbursement, but that we can surely talk around. That should be coming very low on the list. So it's a problem of culture, I think, of the older physicians becoming trained in being able to conduct virtual consults as well as they conduct their physical consults. And they should feel satisfied that they can do just as well as I have learned seeing somebody virtually. I see patients all over the world from this room just as well. And the ones that I can't work out, I tell them, go and see my colleague, Professor Khurana or Dr. Deb, who are to hand, and they might do the vice versa. So I think we need to check ourselves out first before doing the othering phenomena. It's they who are not coming over to see us. It's not always them. It's possibly a lot of it is us. So I think we need to meet them halfway house. Otherwise, people are being inconvenienced. And how will we ever reach those places in North Carolina or in Mizoram where there's hardly a neurologist around? And,
I think we learned a lot during COVID. We got used to the virtual consults, which we were not doing it earlier. And I think a good model is a hybrid model where we now currently we can adopt that, taking a patient for the first consult, maybe in person, and then follow up in the.
Yeah, absolutely. That is what, because we used to do lots of teleconsultations, and what we found, patient in the first consultation, they come and do physical examinations, and then patients who are 100 miles away, they can connect over virtually. But challenge, one of the things which comes in virtual consultation is writing in medicine. Some of the medicines, especially neurology, which are sedative sort of things. So as per the government, so some of the medicine cannot give on teleconsultations. So
legislation,
so that's one challenge there.
Well, those can be fixed, but the main thing is the culture.
There's one question by Philomena to Dr. Charles. She asks, do you agree with thrombolysis in the ambulance with telestroke?
I'm sorry, I missed the question. What was it?
The attendee asks, do you agree with thrombolysis in the ambulance using telestroke?
Great question. So, and let me answer the way I understand it might be asked. So we try to see our patients, quickly when they present to the emergency room, and then we don't wait for them to get in years past to wait to get the full TPA. When it was TPA, they would do the bolus and they'd hang the bag and then put them in the ambulance and get them headed our direction. That's one of the reasons we like Tenecteplase, TNK, because it's just a one shot. They don't have to have that infusion going on for an hour. So now, now pretty much they get it and they come. I'm not aware in our network of whether anybody is actually making the decision in an ambulance whether to give thrombolysis or not. It could be, because now we have stroke ambulances. I mean, in some cities there are hospital, there are places that have stroke ambulance where they're getting a CAT scan in the ambulance, while they're being taken to a main facility and making decisions about treatment, in the ambulance. We don't have that kind of capability, at least in our network. So ours still go to an emergency room. We see them, we make a decision, we get them TNK really quick if they need it. Where they come our way, or we find that they're 10 hours, 8 hours into it. There's a large vessel occlusion. They need to come to us for thrombectomy. So those are the kind of things that we're doing now.
Sure, thank you. And there's one more question regarding what other neurological disorders are presently being attended to under the teleneurology program under the network, other than stroke. So this was, of course, the telestroke network, and I'm sure there are other disorders too. So if Dr. Nandita, maybe you could answer that.
Yeah, at UMass, and I'm sure at other institutions now, we have our, of course, robust telestroke program, but we also have a teleneurology program where we can do inpatient consultations for the hospitals around the area. And so I'm involved in that, and we'll get consults. So again, the main challenge being if it's across states, we have to be licensed in those states. But basically same idea, you video in, it's not as urgent, so you don't have to do it, right away, such as for stroke. But, within the business day, kind of call in, and then you're able to see the patient if you need to. oftentimes it's kind of a post stroke question of, okay, they came in for question stroke, here's all the workup, what are the recommendations? So we don't always have to see the patient, I would say. Sometimes it's a conversation with the physician. But sometimes, if we need to video in, we can. And so we see all sorts of diagnoses through that. And then we're using it for outpatient neurology for sure across the board.
Excellent. Thank you.
Dr. Deb, yes, sorry.
Yeah, Arthur.
No, a follow-up question, Dr. Deb, on that one. I'm quite interested in pushing education forwards and having consistent policies across countries. Well, first of all, within countries, you've got so many states, 51 states, different credentialing, different licensing, so many different universities. Does the American Academy of Neurology have some guidelines or standardization of medical education for trainees at undergraduate neurology, postgraduate neurology, to have consistent, finished medical professionals at the end of the training for USA? Because we also have the National Medical Council, which basically watchdogs the entire educational environment. And it's very important that we indoctrinate both of these and make it more people-centric and country-centric, and 2024 onwards, rather than having 18th century models of care. We need to have a proactive 21st century model of care, which is local regional specific. So the question is basically, you have given us your format of training and how you're holding your hands out. So who do you link up with within the Americas for having a structured, standardized training program? And where does your telehealth, teleeducation come in, please?
Yeah, it's a very good question. I mean, of course, for the residents and fellows, there's the ACGME, with the Accrediting Council for Graduate Medical Education. So, they write all the rules for the medical education program in general. But as I was mentioning, there wasn't anything specific to global neurology. Now I have to look and see if they have anything at this point. A few years ago, I think they had it for specifically like global health fellowship through child neurology, but I don't know if they've now expanded that. So I think that would be the ultimate goal, is to have it kind of a part of the ACGME where you can, anybody can go there, standardized competencies, and then, you can implement it the way you want, but kind of follow that. As far as I know.
How much does the ACGME incorporated the teleeducation into their portfolios?
That's a good question. I don't know that they have. I think there's definitely guidelines. I know AAN has kind of robust guidelines now on teleeducation and teleeducation models and how to do it. I don't know if ACGME has incorporated that. It's a good question.
They have to, otherwise it won't take off in the way we want it to.
Right. I mean, it's not formally taught for us, even though we've had kind of modules here and there. I would say, since enough physicians are doing telestroke and teleneuro, we often have them just come and shadow us, watch us do it. The fellows, the fellows definitely get opportunity, but the residents, I would say, it's not quite standardized.
So practically, there will be different formats of training in different countries, but I think the overarching aim is to transmit the education, and if we achieve that, that will really serve the purpose. So I think we've come to the end of the session, and I would really like to thank from the bottom of my heart Professor Tegler and Dr. Nandita to wake up so early in your time. At their time, it's probably early in the morning, around 8 a.m. right now, and 8:30, I guess. We started at 7:30, and
8 in the morning.
Partha too.
Much afternoon. Yeah,
it's afternoon.
1:30 in the afternoon. We
had a truly global discussion today.
Yes, I learned a lot.
And I thank each and every one of you to have joined us and really given us a great, in fact, amazing learning and equally amazing discussions we had after that. Thank you, everyone.
Many thanks to you and Biplab for spearheading the teleneurology subsection from the Indian Academy of Neurology. We are very grateful to you too for pushing the envelope of teleneurology, telehealth for all of us in India and abroad.
Thank you. And we hope to have many more of such programs. Thank you.
Absolutely.
Thank you for contributing.
Absolutely.
Thank you.
Thanks, Professor Tegla.
Bye.
Thanks, Dr.
Bye
Deb.
bye.
All right. Thanks
Have a great
again.
week.
Thank
Have
you.
a great weekend.
Namaskar.
Bye.
Namaskar.